This conference will now be recorded.
Hi everyone, my name is Dr. Bhavna Sharma. I work as a medical registrar in the NHS and I'm currently training in the specialty of endocrine and diabetes. Um, Welcome to our session. This is organized by Teacher Academy, which is an academy which is run by doctors and nurses as well as English teachers, which sets us apart from the usual academies. Now, today we're going to be dealing with OAT speaking and the clinical communication criteria which arise in OAT speaking. We are joined today and we're very thankful for Fatima to join us today. She is a professional nurse working in NHS London, so that's the medical service in London. Um, she has an extensive background in obs and gynae as well as diabetes. So she's very good with counseling patients. Some of you guys might have seen her YouTube videos, the role plays that she's done in counseling patients. We're very thankful, Fatima, for joining us. We're very thankful to you for joining us today. What we'll do is in the beginning of this session, I'll go through the clinical communication criteria and then we'll get Fatima on and then she will discuss as to what clinical communication criteria mean to her as a nurse working in the UK and how she uses her clinical communication skills to deal with two particular cases, which is counseling patients. So when Fatima is counseling patients for diabetes, or she's counseling people with long-term endocrine problems, how does she deal with them? And the difficult case of patients who might not be very cooperative with treatment, how does she use her clinical communication skills to deal with difficult patients? Even though we're talking about real life experiences, all of these are very applicable to OAT speaking. One of the very common scenarios which does turn up on your OAT is difficult patient not cooperating with treatment or someone that you need to explain a chronic disease to. One which crops up quite a lot is diabetes. So in that scenario, you're supposed to explain diabetes, you're supposed to talk about medications, maybe you're supposed to talk about injectable insulin and how the patient's supposed to use it, and just emphasize on complying with medications. So it's going to be a very useful session today, a very real session today. Guys, make sure that you make lots of notes and make the best use of this session. Okay, so the learning objectives of this session, uh, we'll identify the various clinical communication criteria which are assessed on your OAT speaking. We'll understand how each criteria and its scoring can be enhanced by using our real life experiences. And we'll use some top tips in the scenario of difficult patients and counseling patients. And hopefully, by the end of this session, we're able to improve our OAT speaking score, particularly in clinical communication. So this is the clinical communication criteria, which is assessed on the OAT. So this is the new OAT scoring criteria. You can see that you're assessed on 5 broad categories, which are your indicators of relationship building, whether you're able to initiate your interaction appropriately, whether you appear respectful and attentive to your patients, whether you adopt a non-judgmental approach, and whether you show empathy to the patient's feelings. The second criteria is understanding and incorporating the patient's perspective. Remember, we've discussed this in our previous sessions as well. You aren't the priority here. The patient is the priority because we're talking about the patient. So you need to incorporate the patient's ideas, concerns, and expectations while you're talking to the patient. So you need to know what the patient wants for this wants from this conversation rather than what you want. Okay. So if the patient wants certain topics discussed, then you discuss them rather than you try and fulfill your agenda. So that's a very important indicator of understanding and interpreting perspective. Unfortunately, this is one of the criteria that most of the students struggle in. Indicators of providing structure. Remember, when you're talking to a patient, you're giving them a lot of clinical knowledge. Now, this clinical knowledge might be very, very familiar to you, or it might be something that you deal with throughout your life. But for the patient, it's going to be completely new knowledge. So it's very important that you provide a purposeful and a logical sequence to your talk, so that the patient can understand you. If the patient has any questions, they might be able to ask them, and they might be able to take a lot from the interview rather than just listening to a lecture and not really understanding anything. Two other indicators are indicators for information gathering. Are you taking a good history? Are you actively listening to the patient? And information giving is whether you are tailoring your lecture or your discussion to the patient's needs and whether you're explaining things appropriately. If you want to know further about these clinical communication criteria, please go to our YouTube channel, and this has been discussed in detail with regards to OET scoring. Now, what I'm going to do is I'm going to hand over the mic to Fatima, and she's going to discuss particular topics on OET speaking and as to how we can utilize relationship building and the various OET clinical communication criteria onto our OET speaking. So let's just get Fatima on board.
Hi guys, can you hear me?
We can hear you. Thanks again for joining us. And we're very, very grateful that you're giving us real life experience working in the NHS and working in the UK.
It's my pleasure. Good morning, everybody. So I'm Fatima Chowdhury. I'm a registered nurse in the UK. I've been registered nurse since 2005. My background, initially I started as an obs and gynae nurse in the hospital, working in early pregnancy and gynecology. So that's where I developed my counselling skills as I was dealing with a lot of etc. So as you can imagine, it's a field where your counselling skills are really important. I left the hospital environment about 8 years ago, and I've been working as a practice nurse in the UK, which is where I'm based in a general practitioner, so in the GP surgery. So my role is very, very varied. I do lots of different things, but my specialism, my interest is in diabetes. So I do about 5 sessions a week, just seeing patients with diabetes. So we're going to talk about communication, talk about counselling skills today. So the main thing here is your relationship building with your patient. Now, your first impression you give to your patient and their family is what will make your patient kind of decide whether they want to listen to you or not. So you may feel a little bit awkward, especially when you're very new to it. It does feel awkward, but the more experience you get and the more passion you have in the area where you are practicing, you'll feel more and more confident. So when you introduce yourself, try and be confident. Don't be nervous, because the patient is always also anxious about what they are coming in for, what you are going to tell them. So your opening to them is going to make them feel at ease. So some of the things I would say, consultation skills are very different. I've worked with doctors, I've worked with medical students, student nurses, professional people, and one thing you notice is everybody's consultation skill is different, and you develop your own. You will find your own way of working, your own communication skills, and that you're comfortable with. That over a period of time you realize, okay, that's good, because straight away I was able to calm that patient down, or you were able to draw them into listening to you. Okay, so introduce yourself to the patient, be confident, and make sure you check with the patient that they are the correct patient, confirm their identity, and make sure that they're comfortable. Are you okay? Seating, lighting, distance to where you're sitting. You have to take all of these things into consideration. Some of the things that I do, if it's a patient, for example, with my diabetes patients, I've been working with them for some years and I kind of know who they are. In my previous consultation, I will write something down from our conversation. For example, they might say to me, oh, their daughter's getting married, or they've recently had a grandchild, or they've recently retired. I'll just make a quick note on my social notes about that, and I ask them about that. I say, oh, you had a grandchild, how is he or she doing? And immediately for them, they feel as, oh, she remembered that. Yes, she remembered that. So they kind of think, okay, so she's showing me interest. Yeah, so that really helps. Okay, if it's your first meeting with the patient, always kind of clarify what they are here for. So if you're seeing a patient for the first time, introduce yourself and say, you're here for your diabetes review, and we're going to talk about that today. Is that okay with you? All right. So to the next slide. Okay, so what you have to remember in this part is that this appointment, the conversation is not about us. This appointment is the patient. Okay, the main reason for this appointment is your patient. In diabetes, in this country, we have something called diabetes care planning. And the gold standard for this, what this basically means is you're handing the responsibility of this disease or this illness to the patient. So the patient is basically in the driving seat. They will decide what is important for them to discuss on that session. And your role is to kind of help them steer, help them kind of explore how you can help them achieve those goals. Okay, so their ideas, their concerns, that is your priority. Okay, so handing the patient the responsibility. So when it comes to care planning, you can't talk about everything. You have to find out what is the most important thing they want to achieve today. So you may say to them something like, there's lots of, I can understand there's lots of things going on. What do you feel is the main priority today? What do you want to talk about today? Okay, so they may say, my main thing is I can't remember to take my medicines all the time. Okay, so okay, let's talk about that. What do you feel is the best time? Why, how is your schedule in the day? Exploring that, you may then end up that the best time for them to take the medication is in the night time before they take their dinner, and then exploring ways to kind of put the medications in a certain place, or putting a note on the fridge. Lots of things you can explore from that. So audience awareness is really important. How much they understand is really important, and like sympathy and empathy. Always agree with the patient. Remember, as many of you may already be exposed, or family members be exposed to chronic diseases. It's not a nice thing to have. It's a life-changing event. So acknowledging that I understand this is a lot for you, that really makes them kind of think, okay, right, this is a lot. She agrees that this is a lot. Okay, how much they know about the disease, and it's always going to be different. if you're seeing a patient for the very first time who's newly be diagnosed with something, compared to a patient who's been diagnosed for many years and they've attended to review, their results and things like that. So they're already aware. So a new patient coming in who's been diagnosed with something is going to view that situation very differently from somebody who's already been, diagnosed for many years. When you're making your goals with the patient, in the UK, we have something in nursing called your SMART, the acronym SMART. So making sure the goals are specific to the patient, making sure that it's measurable, so can they achieve it, making it realistic. Yeah, so, something like, for example, losing weight. I want to lose a stone in the next 3 months. Is that realistic for them? Yeah, and putting a time onto it. So always kind of putting a review date, so they know that they have got this amount of weeks or this amount of months to be able to achieve their goals. Okay. Going on to our next slide. So providing structure. So this is really important when you're speaking to patients. This is my first session, so many of you may feel like she's a little bit everywhere. Yeah, hopefully I'm not too everywhere, but it's really important when you're talking to patients that you have a structure. Okay, so you know in which way you're going to communicate with your patient. With my diabetes session, I always, before I call my patient in, I always review their notes, so I can get a rough picture of them in my head. So this patient is 60-year-old, he's a male, he's South Asian, and he's had diabetes for 10 years. These are the medications he's on. And then I look at his blood test and I review his blood test and I compare it to his last review. So when they come in, I'm giving my 100% attention to my patient. I am not looking at my screen anymore. I've got their information in my head. So now I'm going to face my patient and I'm going to talk to them. Okay, that is really, really important. You will get, many times you go to visit the doctors and they're just looking at their screen and they're typing things. They are not having eye contact with the patient, and that isn't really good. You need to give your 100% to your patient, acknowledge what they are saying, nod your head, agree with them, and they will feel that you're then listening to them. Okay, so when I'm talking to my patient, I'll say, right, you're here for your diabetes, how have you been? Has anything changed? So for example, looking back at your notes, if you notice previously the patient's diabetes was quite well controlled, but now it isn't. So ask them, how have you been? Has things changed in the last 6 months? What's been happening? They might then reveal to you, they've been a bereavement, or they've been on holiday, or the summer holidays been full of weddings and parties, so the diet, lifestyle hasn't been the best as it could be, so you're getting that information from them. So structure your consultation. So going through the medical history, asking them about any changes, asking them about medication. Are they compliant? Are you taking your medications on time? One main question I ask is, how many times in the week do you miss your medication? And that usually is like, oh, how does she know that? Yeah. So it's not always about, are you sure you're taking them? Your prescription is saying you've not been taking them. How many times do you miss your medicines in the week? And that gets you a lot of information back. So rather than having closed question, you're asking them opening questions, okay? And then going through the blood test results, explaining to them. It's really hard for us clinical practitioners not to use words that the patient doesn't understand, okay? So instead of, saying, renal disease, what is renal disease to a lay person? What does renal even mean? Okay, so talking about their kidneys maybe, how do your kidneys work? Why is that so important when it comes to diabetes and your blood pressure, etc. Okay, so talking about the results, and then you talk about, okay, now we've discussed your results. This is what is happening. How can we help you to gain better control? Okay, so talking about what is important to them, and do they feel motivated and confident enough to make any changes before the next review. And always in the end, summarize. So this is what we've discussed. We agree that, you know, your diabetes has, you know, gone up a little bit, and we agree that it could be because of these lifestyle changes. But, you know, let's help you to make some changes, and we will bring you back in 3 months or 6 months, depending on the clinical situation. Okay. So this the next slide. So information gathering. Now this is really important. Like, you guys are probably learning about history taking. Some of your patients are going to be fantastic historians. They will start from the beginning and give you everything you want to know. And they're like, you know, the classic good patient. But most of the time, patients will be everywhere. You know, they will give you a history, 1 minute something, and then it will all be everywhere. Your role will be to kind of collate as much information as you can from their history. So you're active listening. So listening to what they're actually saying, making notes if you have to, or just convey, okay, so you're feeling really upset that you've not been motivated, or you're feeling demotivated, you don't want to take these medicines anymore. You know, so listen to them, ask them questions, ask them open questions. Don't ask, try to avoid leading questions, okay? So you think you're eating too much white rice then? Yeah, something like that, you know. So try and avoid, just say, what do you think is in your diet that may be making your diabetes go up? Or let's talk about your diet today, or tell me about your diet. You know, go through their breakfast, lunch and dinner, for example, and you'll be able to collate a lot of information. Anything that's vague, you know, clarify. So if they say something and you're not sure, just say, tell me more about what you mean by this. Yeah. And again, just summarize. Okay. And the next slide, information giving. So this is the impact of how you provide information, checking that the information you're giving to your patient is taken on board. So again, exploring their ideas, their concerns and expectations, and, you know, tailoring your response to what the patient feels is important. And then clarifying any questions or different, you know, questions they may have, and kind of, like I said, avoiding like to use any difficult medical terms. So key components for your, so going on to the next slide, sympathy and empathy. Yeah. Now, to develop what we call a therapeutic relationship, it's really important that you develop that trust, that respect with your patient, and how you show them genuine interest, that relation, that's empathy. Okay. So, you know, when you're talking to your patient, let me give you an example of a difficult patient, and how I kind of provided empathy, sympathy, and how I actually ended up having a very good relationship with this patient in the end. So when I started in my current role in this clinic, usually the doctors who are specialized in diabetes were conducting their diabetes clinic. So when I started, this was a very new thing for the patients, actually seeing a nurse and not a doctor. So patients get a message that you have your appointment with the nurse. This is all it will say, nurse, you know, not specialized, nothing. You have an appointment with your nurse for your diabetes review. So when the patient came in for his routine appointment, I had already looked through his history. I knew, you know, he was in his 60s. He was diagnosed with diabetes 5 years ago. His diabetes control was fairly poor, and that he's non-compliant. So he doesn't take any of his medications. And previous doctors have written in the notes, non-compliant medicine. Okay, so the first thing, as soon as the patient came in, even before I could say hello and introduce myself, he was very angry. Why am I seeing the nurse for? Who are you? Why am I not seeing the doctor? What is this appointment about? I don't want to see anybody. I don't want to speak to anybody. And he was literally ready, not even to come into the room. He was ready to go. He had his shopping bag with him and he was ready to leave the building. So I just let him carry on, whatever he wanted to vent out. You know, he repeated the same thing. Why do they keep calling me for? I don't have diabetes. I don't want to see anybody. I don't want to talk to anybody. Why isn't this appointment with the doctor, etc., etc. So I let him finish, and I said, "Hi, you know, my name's Fatima. I'm the practice nurse here, and you've been invited to this appointment to talk about your diabetes. I'm really sorry. You're feeling really angry. It appears to me that you're a bit upset about why you're seeing me. Why don't you come and sit down and we can have a little chat about it?" Yeah. And majority of the time that works. They feel, okay, she's talking a bit different, or okay, let's see what she's got to offer. And actually those were his words. He was like, oh, okay, let me see what you've got to say to me. Okay. So so I just said, you know what, tell me, why do you feel you're here? And he said, well, they keep telling me I've got diabetes. I don't have diabetes. I don't believe I have diabetes. They keep telling me this and that, but I don't. I said, okay, what do you know about diabetes? So we're starting right from the beginning. So he's here for his diabetes. What does he actually know about diabetes? Okay, so we started right from the beginning. I said, tell me what you know. And he was like, I don't eat any sugar. So how can how can I be diabetic? I don't eat any sugar. And that is a very common response you get from patients. They automatically feel that it's the sugar. And I said, okay, so is it just the sugar? Do you think there's anything else that can give people diabetes? How about your ethnicity or your other risk factors like your weight, where you're from, diet, lack of exercise? And nobody's told me anything. Nobody's told me anything. I don't know. I don't know. I don't want to know. It took a while, okay, but what my main priority was to keep him there and talk to him and gain that relationship with him, that he can open up and he can vent out his frustration. So talking to him, what appeared was that a few years before he was actually diagnosed with diabetes, that he was actually pre-diabetic. So this is when patients are at risk of diabetes, but they're not diagnosed until they meet a certain criteria, and nobody told him. So nobody told him that he was pre-diabetic. If somebody had mentioned to him before, he would have made the diet and lifestyle changes which would have prevented him from actually getting the diagnosis. So I said, look, I'm really sorry. I don't know how you would have got lost in the loophole like that. I'm really sorry for that. But now that you're here, let's talk about it. Yeah, let's talk about what diabetes is. Let's talk about what the symptoms are, if you have any of those symptoms. And let's talk about, ways that we can help you. If you don't like medicine, I'm not going to force you. Okay, because one of the things he said to me was when he comes to see the doctors, all they do is just write a prescription, give it to him, and that's it. Nobody's discussed anything with him. Okay, so yeah, so we spoke about diabetes, the symptoms. I have a way of using diagrams and charts, and picture images are really good. So depending on what environment, what specialism you guys work in, pictures, diagrams, charts are fantastic. Okay, so one of the charts I use is a HbA1c that monitors patients' overall background glucose levels, and it's color coded. So you get from like green to blue to like yellow, orange, and red, which basically signifies danger. Okay, so as soon as you show this chart, this traffic light system to people, and then you say, look, this is where you are, and they say, oh, but that's in the red zone, that means danger. And I said, yeah, that's where you are. This is the part where if your number is in that box, then you're more at risk of developing complications with diabetes. Do you see now how important it is for you to make these changes so that we can bring you back to the green box or the blue box? Okay, so tip there. Diagrams, color-coded charts are absolutely fantastic. Okay, so long story short, in the end, so we agreed that he wasn't going to take any medicines. At that day, medicines wasn't important for him. That day, in the end, it was more important for him to know what is diabetes and how it will affect him. So in the end of that consultation, you know, we agreed that I was going to call him in a couple of weeks to see how he was getting on with his diet and lifestyle changes, and that, you know, I'd see him back for another blood test and see how he was. And the consultation left by, why didn't I meet you 20 years ago? Like, if I had met you and you gave me all of this advice, you know, then maybe I would have made those changes and I wouldn't be here today. And he apologized in the end. He apologized for his behavior when he entered the room. And now the patient doesn't see anybody unless it's myself, which is really nice because I've developed that relationship with him. And don't forget, this comes from your initial meeting with the patient. So how you portray yourself the very first time you meet your patient is going to make or break your relationship with that patient. So that's really important. So yeah. So top tips, counseling on chronic diseases. Okay, so I think we've talked a lot about this one. So emphasizing on the lifestyle changes with the diseases, you know, how will the patient make those changes? What are their goals? Don't forget, it's not about you, it's about them, okay? You can't make, you know, 10 different changes at the same time. Put yourself in that patient's position, okay? Understand that this is maybe the first time they're being told that they have diabetes, or this may be the first time that they're actually being told that if they don't improve their diabetes, it will affect their future and their life, okay? And understand that, you know, the changes that, you know, we make for them is going to impact their life, all right? Signpost them to any resources. So if in the UK, we have Diabetes UK website. So we signpost them to those, offer them earlier appointments if needed. If you're talking to a patient and you feel, okay, they're listening to me, they're actually adjusting to the idea of this, they appear to be a little bit motivated now, yeah, don't give them another review in 6 months. Try and keep them in your grasp. So say, look, is it all right if I call you in 2 weeks just to see how you're getting on? Shall we do another blood test in 3 months so we can have another catch up about how you've improved? Yeah, not how worse has it gone, but how have you improved? So say encouraging things like that. Always kind of saying, you know, I really feel you've listened to me today. I'm so glad that you appear so motivated to me, you know, and you can do this. Always leave them with something positive, okay? Next slide. So counseling on long-term conditions. Again, I think we've covered a little bit of this. So how do medications work? What are the side effects? Why does the patient need these medications? Sometimes patients don't understand why they need to take medications. You know, they'll be like, why do I have to be on so many medications? With a lot of research, diabetes is really, really broad. With a lot of research now coming in, you know, we know that patients, if they're able to make diet and lifestyle changes, that they're able to actually put the diabetes in remission. Obviously, you don't want to say that to the patients like that, but kind of encourage them, look, you know, I always say to them, look, 3 things in that will help your condition. Yeah, it's, you know, your medication, your diet, and your lifestyle. And all 3 of those things need to be balanced. You've got to give 100% each to those areas. And if you're able to do that, then you'll see some improvement in your condition. And so a lot of patients don't understand how medications work or what their side effects are. So it's really important to actually talk to them. And for nurses, it's really important that you stay within your professional boundaries. Okay, I'm not a prescriber myself, so although I know a lot about diabetes, medications, you know, about the side effects, etc. I do not prescribe people. So I know by looking at their results what they may benefit from it, but after I've discussed it with the patient, I will go and speak to my doctor, explain the situation to them, and get the doctor to prescribe. So nurses, always remember, you need to remain within your clinical expertise and your professional conduct. Okay, how to take these medications, really important you explain about injections, inhaler techniques. That's a classic one. Patient, doctors nurses, if you work with patients with asthma, so when I work with patients with asthma, one of the things that we do is we assess the inhaler technique. So you assume that the patient knows how to take the inhaler, but actually when you assess them, it's a completely different story. Okay, I'm sure you've seen the famous video going around with the patient spraying the inhaler like a perfume. One I had personally myself when I was talking to a patient who had very poor control, and she's saying to me, I'm using my inhalers, I'm using both of them. I said, okay, show me, how do you use them? And I tell you, it was one of the most funniest thing, but I could have jumped out my seat, but I didn't. So this is how she showed me she takes the inhaler. So she brings it here, she sprays it, and she goes like this. So I stayed as calm as possible. Okay, and I said, how long have you been doing it like that? Oh, as soon as they gave it to me, they said that I just need to press it and I need to breathe it in. Okay, yeah, so can you see how, assessing your patient's inhaler techniques or how they're taking medicines, it's so important. So obviously with that, you go through the correct technique, you show them the videos on Asthma UK website, and then you assess them and then bring them back again. And we always ask them to bring their inhalers with them so we can actually see what they're doing and then show them the correct way of doing it. Okay, and say it's like I could have easily laughed at that patient and said, oh my God, is that what you've been doing? No, this is what the patient's perspective is. This is what the picture she got in her head because of the way she was told. Okay, so say, oh, I'm sorry you've been doing it like that, but that's not the correct way. Let's talk you through how you should be doing it. All right, I think that's it, guys. I did want to mention to the nurses, like in the UK, we have the Nursing Midwifery Council. Now, this is when you become a registered nurse, you need to abide by the laws of the code of conduct, okay? And so there's 4 principles on that. So prioritizing people, practicing effectively, preserve patient safety, and promote professionalism and trust, which is so important, okay? Yeah, open to questions, I think. I'm sorry if that was a little bit all over the place. Dr. Bhavna?
Thanks, Fatima. That was very, very useful as usual and very, very interesting lecture. Lots of interesting stories. Thanks for all your help. I think real life experience is extremely important, especially to take back if you aren't that familiar with clinical communication skills. If you come and work in the UK, guys, you'll have lots of different the demographic of patients is really different. That's why we emphasize on clinical communication skills. These aren't going to be your usual patients that you give medications and they'll accept it. You need to explain to them why they need these medications. You need to emphasize that they need to take the medications, why they need to take the medications. They need to know the logic behind taking these medications, and that's when they'll take them. If you hand a patient an inhaler or an insulin injection and you think that because you're a doctor, you're a superior human being, or you're a nurse, you're very, very intelligent compared to the rest of the population, they won't really listen to you. And that's why clinical communication skills become extremely important, and that's why they're assessed on the OET speaking. But thanks, Fatima, for joining us today. So this was a very different perspective on speaking from a nurse's standpoint. So I hope you guys have learned a lot today. I hope you've made lots of notes. All of this session will be uploaded on YouTube. Fatima gave out a number of phrases which you can use in your day-to-day life because they were native English phrases as to how you would counsel your patients. So you can try and use them, make some notes from our YouTube videos. But thanks, Fatima, for joining us. Extremely useful lecture today. All right. So Atul has asked how to tackle medical negligence. So we did cover medical error in our previous session. So Atul, if you go to our YouTube channel, it's the same spelling. It's called Teach Your Academy. It talks about medical error and how you would approach a patient with medical error, particularly on OET speaking. Rohit has asked about OET not being accepted for visa. Rohit, if you're applying for a tier 2 visa, you're exempt from using an English exam on your visa application. So if you have GMC and you're applying for a tier 2 visa, you don't need an additional English exam. So don't really worry about it. Even if you've applied to the MRCP pathway and you have your OET on top and you have your GMC, you don't need any other English exam. So that's the session for today. Thanks everyone for joining us. I hope you've learned something new today, and I hope that Fatima's extensive experience as a nurse working in the UK has helped you out, and probably it might also help you become a better doctor or a nurse in terms of clinical communication, because I think that's something that is a skill that we are losing as doctors and nurses. Particularly with the stressful scenarios, I think we're losing clinical communication. So it's very good to just come back to what we started out when we tried to become a doctor or a nurse. We wanted to help out people. And I think in order to help out people, you need a lot of clinical communication. You need to be a good doctor or a nurse when you're speaking to your patients. And I think Fatima has helped provide that perspective today. So thanks again, guys, for joining us. You can visit our website, www.teachyouracademy.com. In case you want to ask anything about our writing, speaking checks or group discount, the contact number is on your screen. Thanks, guys, for joining us today. And I hope you keep safe and I hope you're doing well. And thanks, Fatima.